Dr. Fogla.
Yeah, great. Leaving from where Rishi has left off, I'll try to just quickly give a brief overview on the practice pearls in laser refractive surgery and intracorneal ring segments. I'm supposed to cover this in 6 minutes. So the current options for laser refractive surgery in clinical practice are basically PRK, flap-based procedure like LASIK, and the KLEX or the lenticular extraction. And you have different machines where the procedures are called a SMILE, Clear, Silk, or the Smart Sight. And each procedure has unique advantages and patient-specific indications. Now, in the pre-op investigations, I think getting an accurate refraction is critical because you need to either use the fogging technique to get the right measurement or do cycloplegic refraction and then estimate what correction you need to do. You need to get your astigmatism right. So just not a topography wouldn't be sufficient. Do a tomography as well. And if possible, do aberrometry if you're going to use any ray tracing techniques to further customize your treatment. And we look at all the four axial map, the anterior and posterior elevation, and the regional pachymetry. In borderline cases, you can take assistance from the Corvis or the ocular response analyzer to try and analyze the presence of any abnormal corneal biomechanics. Epithelial mapping using either high-frequency ultrasound or the high-resolution anterior segment OCT is also quite useful because it helps identify any masking of the surface irregularity that occurs by the epithelium. In majority of these three procedures, the outcomes, almost 99% achieve 20/40 or better, and 94% achieve 20/20 in FDA studies. If you look at the LASIK, the limits are basically myopia up to 12 diopters, hyperopia up to 6, and the astigmatism up to 6. But in real clinical practice, we have stopped going up to -10, -12. We know that the safe limit, leaving behind a sufficient amount of residual bed, we correct only about 8 or 9 diopters of myopia because we don't want to leave a cornea that's unphysiologically flat because it induces a lot of spherical aberration. So in that scenario, maybe a phakic IOL would be a better choice. Microkeratome flaps definitely are not as customizable as femtosecond because the flap diameter changes with the microkeratome flap depending on the keratometry, but with the femtosecond, you can get the same diameter of the flap, and the thickness is much more predictable when using a femtosecond. You can do a wavefront optimized, the wavefront guided, topography guided, or the new one that's coming out, the InnoVise, which is a ray tracing guided treatment. Complications of flap, yes, that's a definite risk factor when you compare with PRK or lenticular extraction, but the incidence is very low. Like I mentioned, the visual outcomes are pretty good, and a 10-year study shows that the need for enhancement with the modern laser system are much less. Remember, the excimer laser has evolved from a broad beam to scanning slit, variable spot, and currently most laser systems have what is called as a flying spot. And because the spots never fall on the same spot repeatedly, they are more gentle on the cornea, just like what you mentioned, smart surf. In wavelight, you have the perfect pulse. So the technologies, they give a different name to it. The lenticular extraction, the limits are about myopia for -10, astigmatism up to -3, but hyperopia is still under investigation. Because it's flapless, the flap-related complications of LASIK are not there, possibly gives better biomechanical stability. And studies have shown that the incidence of post-refractive surgery dry eye is definitely lower with lenticular extraction, possibly because in the anterior cap, the corneal nerves are preserved. The disadvantages are lack of customized treatment, and if you do need to do an enhancement, you need to either fall back on doing either make a flap and do a enhancement or do a surface ablation. And studies looking at the corneal nerve regeneration using confocal have shown better preservation of the corneal nerves using the lenticular extraction. The contraindications when not to do a laser refractive surgery, definitely unstable refraction, any abnormality of the cornea in terms of thickness, the presence of guttae or neurotrophy, or if there are any lens changes, or if the patient has glaucoma or uveitis, any underlying autoimmune disease, if the patient has anxiety, depression on antipsychotic medications or unrealistic expectations, these are again, some of them are relative and some of them are definite contraindication. So the clinical objectives of performing a laser refractive surgery is that first, determine the visual requirement and patient's expectations, quantify and identify the refractive error, do the diagnostic test to assess the suitability, discuss all the various surgical, non-surgical options, risk benefits, but also emphasize the possible side effects, like commonly you get dry eye, fluctuation in vision, and sometimes the need to enhance or the need to wear glasses once they attain presbyopia. Provide the follow-up care. It's very important that for every patient who undergoes refractive surgery, you should provide the information regarding the pre-op refraction, the keratometry, the maps, so that if this patient later on requires any secondary procedure like a cataract surgery, we do have the pre-op data based on which we can provide the patient a better outcome. To avoid keratectasia, I think looking at the tomography is very important. You look at the Bellin-Ambrosio display or look at the other screening software that your tomography device provides. You can look at the PTA, which is percentage tissue altered, which is basically flap thickness plus the ablation depth divided by the central corneal thickness. And if this is more than 40%, then there is a risk for ectasia. Other thing would be, younger patient, higher amount of ablation and leaving behind a thinner bed. That's basically a comparative between PRK, LASIK, and SMILE, the advantages, disadvantages. Intracorneal ring segments like Intacs, Kera rings, Ferrara rings, or variable thickness rings, these are all made of PMMA. They come in various thickness and various arc lengths and various diameters as well. They are basically used for keratoconus and post-LASIK ectasia, and the idea is to either make the cornea more symmetrical and prevent the need for a corneal transplantation future. The problem is none of them have a very definite nomogram, so the outcomes are not very predictable. In terms of doing the case, its implantation, the site of implantation, the thickness should be at least 400 microns or more. The cornea should not be steeper than 58 diopters, and there should not be any other corneal scarring, or the patient's expectations of the procedure should not be unrealistic. You can put either a single or a paired segment depending on the morphology of the ectasia. So in this case of an inferior cone, a single segment placement can result in the cornea becoming more symmetrical, especially reduces the coma and results in a better, best corrected visual acuity. Complications can happen. You have migration of the ring, you can have vascularization, sometimes the overlying cornea can melt over time, you can develop secondary infection. But I think with follow-up, and if you see any early signs of complications happening, it's a reversible procedure. You can always pull out the ring, don't wait for the complication to happen. So basically, this is a short presentation giving a comprehensive overview of the laser refractive surgery in the intracorneal ring segments. Patient satisfaction with proper selection of cases is over 95%. And in future, I think advances in AI-driven screening and custom treatment planning will improve outcomes and improve the safety of these procedures. Thank you for your patient hearing.
Yeah. Thank you, Dr. FOGLA. I think that's a lot to cover in just 6 minutes. You still did a good job. And as Sunita is setting up, Dr. Sandeep, yes.
Yeah. So in my clinic, because it's a referral clinic, I see a lot of patients with a neuropathic ocular pain after LASIK, and FDA also came up with a guidance recently alerting to this problem. Just want your opinion about how much do you see it and how do you deal with it, and can you predict it?
I think, yes, this is something like what you call as pain without stain. That means you look at the surface looks nice, but the patient has, I think it's in some patients, confocal have shown due to abnormal nerve regeneration. So the nerves that regenerate, at the end they form like a neuroma or something, and that results in the patient feeling pain. It becomes a hyperesthetic cornea, even normal. So we kind of talk to the patient and tell them about the post-operative need for lubricants. Sometimes I ask them even to wear plain glasses if they are doing prolonged screen time to avoid the breeze or anything from touching the cornea. But it's not very common, not that in every patient, but yes, you occasionally do get a rare patient who has this problem. Then we resort to using long-term use of cyclosporine, and we find that keeping them on low-dose topical steroids for a prolonged period of time may have a alleviating effect. The role of oral vitamin D is also being considered. People give supplement with oral vitamin C as well. But the exact cause, because it's not very frequent, you don't come across very frequently, so we don't have an exact answer. Whether there is something that we can look at preoperatively to identify which patient is likely to develop that again we need to, because confocal is not present in every clinic and we don't screen every patient with a confocal to look at the nerve morphology. So if we can figure out some way of identifying which are the patients that may be at risk, we may be able to avoid this problem.
one more to you, Dr. Fogla. With CARES coming in and with a lot of talk on CTAC.
I was just having discussion with
Yeah.
somebody else performing these procedures, and they said that, well, we need to give them real-world outcomes. So it works. To me, I've evaluated both. I've done rings for a much longer duration of time and the stromal segments for the past 2 years. Both of them work the same way. So you can use the rings nomogram to do CARES. Maybe in eyes where the cornea is slightly thinner, or you may not want to put a segment with the risk of extrusion, maybe putting in a stromal segment would be better. But the thing is, PMMA is a rigid segment, so you can achieve much more controlled way. Whereas when you put a corneal tissue, because it's softer, the results, at least in moderate to advanced keratoconus, are very unpredictable. It works in early keratoconus pretty much like a ring does. But like I said, that till we can get much more, we collect data and we can come out with real world results, it still would be an occasional showing off, like, I did this and it works very well. Stromal augmentation is an option. And the best part is, instead of subtracting tissue, you're adding tissue, and it's reversible. So I think that is something we need to look at more. And
Please. Okay. Thank you, Dr.